So welcome everyone to today's Pacific Southwest MHTTC's webinar on the National 988 Initiative and implications for crisis call centers. My name is Ingrid Severson, and I'm the project manager for the Pacific Southwest Mental Health Technology Transfer Center. Thank you for joining us. And just as a reminder that although we are funded by the Substance Abuse and Mental Health Services Administration, the content of this session may not necessarily reflect the views of SAMHSA or the Department of Health and Human Services. In the event that there's any security issues that may occur, the session will immediately end and will not resume using the same join link. And we'll be sending out a separate email to all participants with instructions on how to restart the session. And so right here, for those of you who are not familiar with the Pacific Southwest MHTTC, we are part of a national network of technology transfer centers and serve SAMHSA's Region 9, which includes the US Pacific Islands, Hawaii, Arizona, Nevada, and California. You'll notice on your screen, each region has 3 different colored boxes. The blue boxes represent the addiction TTCs, the green boxes are the prevention TTCs, and the orange boxes, which include our center, are the mental health TTCs. Many of you are joining from all over these areas, which is wonderful. And if you're not from Region 9 and haven't yet connected with your specific TTCs in your region and you'd like to, please do feel free to reach out to us as we're happy to help connect you to other centers. Our role in the Pacific Southwest MHTTC provides training, technical assistance, and resources to support the mental health and school mental health workforce in our region to adopt and implement evidence-based practices across the mental health continuum of care. Our center offers no-cost support for the mental health and school mental health field through webinars like the one that we're on today, as well as through coaching, consultation, resources, and tools. And hopefully someday soon, we can continue with our on-site trainings. Okay, so you can go ahead, Wayne, because with that being said, today I'd like to turn to today's presentation. We're honored to have Dr. Wayne Lindstrom share with us his developments on the National 988 Initiative. And I'd like to start off with a little bit more about our presenter. Wayne W. Lindstrom, PhD, serves as the VP of Business Development and Consulting for RI International, Inc. Prior to this, he served for 5 years as the director of the New Mexico Behavioral Health Services Division and as the CEO of the New Mexico Behavioral Health Collaborative. And during a portion of this time, he was also president of the National Association of State Mental Health Program Directors. Before coming to New Mexico, he was the president and CEO of Mental Health America, MHA, formerly known as the National Mental Health Association. Dr. Lindstrom has almost 50 years of behavioral health experience. So with that, I'll hand it over to you, Wayne.
Thank you so much, Ingrid. Before I dive into the actual presentation, I wanted to provide some historical context for this initiative around 988. I'm old enough as a child of the 50s and 60s to remember when there was no 911. Those of you that are of a younger generation or two have grown up with 911 as just something that's part of our repertoire of daily life. But before 911, it was absolute chaos when it came to accessing help. Annually, every household got a new phone directory of white pages, which was the residential version, and the yellow pages, which was the commercial phone directory. And every municipality had its own set of numbers. Every hospital had its own. Most ambulance services were funeral homes where they used their hearse to double as an ambulance. There were, for the most part, not much in the way of emergency departments. In many hospitals, emergency department was a space in the basement of the hospital. There were no emergency medical technicians in those days. And so if you had a fire, you potentially would have one number to call. If you had a medical emergency, there might be a number of different options, and depending where you lived, a different number for police. If you were at a friend's house who was in another municipality, those would be different numbers that you wouldn't know. And there was a cutout version of the possible options for emergency numbers that you could fill in, and you could cut it out and stick it on your refrigerator in case there was an emergency. So with the advent of 911, we had a single phone number to cover basically all emergencies. But we were very late to the game. The United Kingdom, for example, introduced 999 as their emergency number back in 1937 and 1938. And it wasn't until 1957 that the National Association of Firefighting Chiefs made a recommendation that there be some unifying number nationally to be able to report fires. And that recommendation got absolutely no traction. For those of you that are familiar with the social unrest that existed in the 60s, where many cities were subject to riots, and there was a great deal of violence and protests around inequities in our society, in the Vietnam War, etc. There was a Kerner Commission that was convened to study the root causes of social unrest in our society. And a number of recommendations were made about how we needed to change, reminiscent of what we're experiencing in this country today, to address those inequities. And those recommendations were basically set aside. One recommendation, however, that wasn't set aside, President Lyndon Johnson at the time thought the idea of having a single emergency number that would result in police dispatch was the way to potentially address and prevent the kinds of unrest that was occurring in American cities across the country. So in 1967, AT&T, which used to be called Ma Bell, and that was basically the phone system in this country, announced that they were going to designate 911 as the emergency code, and that was enacted in 1968 and was followed up with some legislative action. And the first call on 911 occurred in February of 1968 from, of all places, Haleyville, Alabama. And Nome, Alaska was the first municipality to, in fact, enact 911. I grew up in Cleveland, Ohio as an inner city kid, and I thought that since 1968, 911 was pervasive across the country. But it turned out that the implementation was basically in America's cities. By 1987, only 50% of the population had access to 911. Today, 96% of Americans have access to 911.
Wayne,
Yes.
could I go ahead and share a couple questions
Sure,
that
please do.
definitely lead to part of this opening. The first question says, the presentation mentions that 988 presents an opportunity to invest in mobile crisis teams and resources such as crisis stabilization centers, et cetera. How is this realistically going to work? I understand the concept of having 988 transfer calls to the National Suicide Prevention Lifeline, but is this resource providing funding for additional longer-term mental health services and supports?
Well, I appreciate that question, but that question will be addressed in about 2/3 of the way into my presentation. So if that questioner would be willing to hold that question, I will more than address it as we go through the presentation.
Okay, great. Thank you. Then the other question is, can you talk about the history of 1-800 suicide?
Actually, I'm not as well versed in the history of the National Suicide prevention line. And that's a piece of homework I'm going to have to do. So I will apologize for that. I will be talking about the National Suicide Prevention Line later in the presentation, but its early beginnings is a gap in my own knowledge base. So I will apologize for that. What really caused the adoption of 911 in more rural parts of America is the Robert Wood Johnson Foundation made a $15 million donation around awarding grants to rural communities to implement 911. And that's when 911 really gained traction in the United States for more rural and remote communities. Now, I want you to think about if you're someone on your worst day, perhaps you had too much to drink and you're walking home from the bar, or you've been depressed and you're having some suicidal thoughts, or whatever the precipitating event may be, and you call 911 or somebody in your environment calls 911 out of concern for you, or they're observing their behavior, what typically happens in most communities? That 911 call is going to result in a police dispatch in some environments. In other environments, like I live here in Santa Fe, you will actually get dispatched simultaneously a law enforcement patrol car, a fire engine, and an EMS vehicle, all with sirens blaring. And if you can imagine being somebody who perhaps is actively psychotic, somebody who's agitated on methamphetamines, being confronted by this flurry of noise and lights, and individuals in uniform, some of whom are armed, approaching you. This is not a situation that is a good recipe for dealing with folks with behavioral health conditions. It doesn't serve to de-escalate situations. If anything, we have enough history now to show that it tends to aggravate and further escalate situations that people find themselves in. This initiative really grew out of a parallel development that we call Crisis Now. This is a model, and I encourage you, if you've never been on the web portal, crisisnow.org, where there's a host of resources on the Crisis Now model. This model includes a crisis call center, which we'll be talking more about, mobile crisis teams, and facility-based crisis services that start with a crisis receiving center that takes all admissions, has no exclusionary criteria, doesn't require medical clearance from an emergency department. Doesn't matter if somebody is actively suicidal, agitated, violent, etc. It means taking all admissions. And these facilities have recliners and not beds, so that they can, in fact, take everyone in, because if you're restricted under licensing standards in states to having beds, you can only have 16 beds with an IMD exclusion. And once the 17th person comes in, you basically have to deny admission. And these facilities are typically paired then with a crisis stabilization center with beds, and with good patient flow management, you can always keep the front door open, and we call it a no wrong door approach. So 988 was designated in July of 2020 by the FCC as the 3-digit emergency number for behavioral health conditions, much broader than the National Suicide Prevention Line. July of 2022 is when 988 is supposed to be fully implemented. This is a quote from the FCC chairman at the time that 988 was designated. And I agree, it is a powerful signal. And our hope is that it does help remove some of the shame that people experience and some of the trauma that's experienced when people are experiencing a crisis at home, on the street, or even perhaps in an emergency department. We know that roughly 30% in terms of suicide rate has increased since 1999. It's the second leading cause of death. 1 in 5 folks experience a behavioral health condition. Youth suicide rates have increased by 10% since roughly 2017. And for every one person that dies by suicide, there's a number of 280 additional people who have had suicidal ideation. And the reality is, we know through the Zero Suicide Initiative that suicide, most of them are indeed preventable. So basically, this is how the 988 initiative came down. In 2018, Congress tasked the FCC with doing a feasibility study on the introduction of a 3-digit code for a national crisis hotline. The FCC responded in 2019 after consulting with the U.S. Department of Health and Human Services, SAMHSA, the VA, and the folks at the 911 Association. And the FCC recommended and later proposed 988 as the 3-digit code for implementation. 2020 is when the FCC initiated the promulgation of rules directing all service providers in the United States to direct 988 calls to the National Suicide Prevention Line by July 16th of 2022. That was followed last October by an act of Congress called the National Suicide Hotline Designation Act, and it advised carriers to coordinate the implementation of 988 with the FCC, SAMHSA, and the VA. And that then was followed up by a state plan process that was initiated by Vibrant. And Vibrant used to be the Mental Health Association of New York City that's been operating the National Suicide Prevention Line. They've rebranded themselves as Vibrant Emotional Health, and they used $9 million in private money, not public money, and offered it to the states to initiate in a 988 planning process. So 49 of the 50 states have indeed applied for those grants. And in January of this year, those grants were distributed to the states with a structured methodology to plan for 988 implementation. The initial draft plans are due to Vibrant by July of this year, and the final plan is to be finalized by December 31st of 2021. I think when we talk about the incidence of behavioral health conditions in our society, even before the advent of COVID, when I was giving public presentations, I was referring to us as a society increasingly in despair. We've learned so much over the years at the effects of adverse childhood experiences, of intergenerational trauma. We see the evidence around us everywhere with regards to increasing suicide rates, mass shooting events, an increasing gap between the haves and the have-nots, inequities growing greater, et cetera, et cetera. So being able to have a system that's responsive to those in crisis seems to me to be a no-brainer. The intent around 988 is not simply to have a number to call in the case of a behavioral health crisis. The intent, in fact, is to build a robust behavioral health crisis response system in every community in this country that's on par with the 911 emergency medical response system, and to be able to have the resources to support it. So going back to the question that was raised earlier about financing, when the Congress acted last October, part of that legislation was to authorize states to levy a phone surcharge on phone usage to support 988. This is not unlike what finances most of 911 and the emergency medical response in this country. It varies by state in terms of whether or not that surcharge covers all of 911 associated costs, or whether it is further supported by other state general revenue funds, or perhaps even county and municipal funds. And there are certain requirements that came out of that act of October of 2020, that it was not just supposed to be focused on suicide prevention, that it's much broader than that. And it required SAMHSA and the VA both to submit a report to Congress within 6 months of the passage of the bill, which is coming up very shortly. And I've not seen or heard much buzz about what that report is going to look like. And as I mentioned to you before, it allows the state to levy fees, and it requires SAMHSA to submit a plan in terms of how these specialized services in terms of crisis response will apply to LGBTQ youth, minorities, rural individuals, and other high-risk populations. And it requires the FCC to also issue a report on the collection and distribution of these carrier fee funds and the feasibility cost of geolocation services. Now, let me address that for a minute. As we've all moved to cell phones, I'm originally an Ohioan. I've lived in different parts of the country. Now I live in New Mexico. But my cell phone number is a 216 area code. I left Ohio last in 2011. If someone is using my area code in terms of attempting to tie me to local continuum of care, it's not relevant. I'm not in Ohio. I'm in New Mexico. So increasingly, we're looking for the use of GPS technology so that, in fact, we can rely on actually where the caller is when making a crisis call, as opposed to making certain assumptions about their locality based on the area code. In attempting to look at 911 as kind of a benchmark for the development of 988, we see that in 2018, the fees for 911 were about $2.8 billion, according to the FCC. And as I mentioned to you earlier, there are other resources that go to support the 911 system. And I have a link there that if you want to see the specific amount of dollars that are raised for 911 in your particular state, that link will provide you with information up until actually 2020. A lot of misconceptions exist about the National Suicide Prevention Line. I had this tendency myself to think of it as a central call center, and it basically is not. It's a network now of approximately 190 call centers across all 50 states. The Lifeline has a set of standards for affiliates in other locations. So when a call is made to 988, it is routed to the Lifeline, and the Lifeline then routes it to the appropriate call center. Unfortunately, now based on area code, as we were talking about earlier, but that's about to change. If somebody calls 988 and presses 1, they get the Veterans Crisis Line. So this is the vision and mission of 988, as Vibrant has espoused it. And the idea is that 988 will have public awareness levels comparable to 911. I can frankly say to you, as having implemented a statewide crisis and access line in New Mexico, that unless people know about a resource, they can't possibly access it and make use of it. State government, other bureaucracies typically don't relate to spending dollars, taxable dollars, public dollars on marketing campaigns. So we tend to use the word public awareness. And certainly in the public health realm, there's been many public health messaging that has gone on throughout our history. But there needs to be, relative to 988 implementation, resources set aside for the continual marketing of 988, specifically for the reason I stated. People need to know that 988 is an alternative to 911. I think for a foreseeable period of time, particularly within the next 5 years, the natural tendency will be for people to call 911 in emergencies. It may be difficult for some people to differentiate whether a particular crisis that they are responding to is appropriate for 911 or 988. And that's why it's going to be crucial, particularly during these first few years, that there are protocols negotiated between 911 dispatch centers and 988 call centers, because there will continue to be calls made to 911. The estimates range anywhere from 6 to 9% of calls to 911 are of a behavioral healthcare nature. I think that's probably a low estimate because depending on the dispatcher, calls can be coded very differently. It's kind of like a mortician and how they decide to sign, a death certificate, and whether it's a heart attack, a stroke, or even suicide. A lot of times suicides aren't reported because of fear of shaming the family, et cetera. So we have similar kinds of issues when it comes to 911 dispatch. As we mentioned earlier, we want to be able to have the resources to de-escalate crises rather than further escalating them, develop coping skills, build on resiliency, and that we have a unified platform that's reliable and timely and has the availability of professional resources. It needs to be high tech, but it also needs to be high touch. It's got to be a resource that's personalized and offers trusted support, and it's got to be payer neutral. You certainly don't want a crisis call center that asks you for your identity, what health plan you happen to belong to so that they can recoup the cost of the call, et cetera. We want this to be a universal resource that takes everybody who accesses services 100% of the time. And there needs to be connection to resources of follow-up. And there are requirements around 988 implementation that the call centers not simply stabilize crisis call situations, but they also offer follow-up services, and those can take a variety of different avenues.
Can I go ahead and
Sure.
break in here with a couple questions?
You bet.
Great. So I'll read them out for everyone's benefit. The first one is actually multi-pronged set of questions. I'm going to read them out and you determine which ones you can answer now. So the question is there a bill in Congress now to fund 988? How much? Is that multi-year funding? Then other questions along these lines. Same question, will SAMHSA oversee this directly? Will an organization like Vibrant or Lifeline? How can we find out about requirements for specialized service providers to participate? And how much will training grants be for specialized services?
All right, well, there are a number of things there. Um, Vibrant worked with Mental Health America in drafting a model piece of legislation for the implementation of 988 and for a statewide crisis response system. I have a slide at the end of this presentation that shows which states have introduced legislation, which are under consideration. And we have 3 states that have actually passed this legislation. So to directly answer the question about resources, there are resources at the federal level, but there are no specific appropriations or allocations necessarily attached to this implementation. There has been a $35 million increase in the mental health services block grant that every state gets. And that increase has been designated for a 5% set aside that states are supposed to spend on crisis response. That's not near enough money. You have 50 states, you have $35 million. That means less than $1 million per state. There is legislation currently in Congress to make that set aside 10% of the block grant and to increase the allocation. At this point, I don't have any crystal ball and Ouija board that I can share with you whether that's going to pass and if it does, necessarily what that's going to look like. There are other things like the recently passed COVID rescue plan that was passed, and within it is a requirement that CMS offer to states a Medicaid benefit for mobile crisis teams for 5 years, where the federal government will pick up 85 cents on every dollar for mobile reimbursement of mobile crisis teams services. So it's going to be up to every state to enact its own set of regulations around how that's going to operate, what the rate setting is going to be, et cetera. But that is also another important resource. But keep in mind what I said earlier about this phone surcharge fee. This is up to each of the states, and each of the states right now, under the grant that they have from Vibrant, are developing a 988 crisis implementation plan. And within that plan is the surcharge. In some states, there's a good deal of blowback. This is seen as another tax. And the model legislation was introduced in Montana, was defeated. Some states are really looking forward to enacting this phone surcharge as a way to fund a more robust crisis response system on par to the 911 system. Was there any more of that I missed, Ingrid?
I think you covered it pretty well. There are some other questions. I'll go ahead and touch on those. The first one, when exactly will the crisis number change? I don't know if if that makes sense.
Oh, yes, it does. July 16th of 2022 is when 988 is supposed to be fully operational. Will there be glitches? I have no doubt in that. Um, there's been some action that if you followed the news just over the last couple of weeks, um, the FCC recognized at the time they promulgated their rules that there are certain jurisdictions that had 988 prefixes in their phone number. Um, so they had to arrange for those jurisdictions to change to 10-digit dialing so that you would dial one, the area code, then 988, and then the 4 digits to avoid a call being routed to the National Suicide Prevention Line. So that's just been happening in the last couple of weeks. So July 16th of 2022 is when 988 will be switched on. Now, there are companies like T-Mobile, for example, who have already built the infrastructure around this and have 988 ready to go out of the gate when that occurs come July 16th.
Okay, great. So we have attendee in Maryland wondering, how can I find out about 988 implementation in my state? Is there a resource people can follow about implementation?
There is, if you go to the Vibrant site, they have a link where they've set up a web portal just for news around 988. RI, along with Vibrant and the National Association of State Mental Health Program Directors, host a national 988 learning community meeting, 9 o'clock East Coast time on Wednesdays, where the latest development around 988 implementation are presented and discussed. And there's typically presenters on special topics and concerns that have come up along the way around 988 implementation. That particular resource is by invitation only. I know we had close to 500 people registered for this event, and I know that because there's so many people on that call now, they're having to change the meeting platform because they've maxed out on spots for attendance. But if anybody, I don't know if the center will keep folks informed, perhaps with regards to how that can be accessed in the future. Right now, I'd offer you my email and I'd arrange for you to get an invitation. But I'd be giving you information that in another week or so wouldn't work for you. So I'm just trying to think of a workaround, Ingrid.
Okay, great. I'm sure folks would be happy to have your email. And all right, well, I'm going to go on. Thank you for that. I'm going to go on to the last question I see here. Actually, there's a couple more. First one being, has the texting option been waived for the upcoming 988 suicide hotline?
No, in fact, it was an oversight, I think, of the FCC at the time they promulgated the rules, and they were only referencing a voice communication. Since that time, the FCC opened up their public comment process around allowing for text and chat. And all the indications are that there will be some new directives coming out and that text and chat will be part of 988 when it's implemented in July of 2022. Word I might say about that, those of us that have been involved with call centers immediately recognize the shortcoming in only recognizing voice communication, because the reality is, and I have grown kids and they won't talk to me on the phone. The only way they'll communicate with me is via text. And the reality is that that's true for all young people. With our New Mexico and Crisis Access Line, when we only had a voice capability, we basically had no utilization by young people. as we began to introduce text and chat, et cetera, then we saw exponential growth in youth accessing that for a resource. So that is critical, and I anticipate that you will see text and chat um, as vehicles that are going to be enabled with 988 implementation. This, of course, does have cost implications. To be able to basically communicate via text or chat requires a greater time commitment than voice communication. And I've seen estimates as high as 2 or 3 times the staffing levels necessary to be able to facilitate text and chat over voice. Some call centers have allowed some of their clinicians to multitask and do more than a single conversation via text and chat simultaneously as a way to deal with this. But I'm not sure that that's ideal.
Yeah, a lot of implications for that. So, all right, those are all the questions that I have so far. Thank you.
You are welcome. Thank you. This is just a slide showing you the growth in call volume between 2016 and 2019. And you can see the orange are abandonment rates. And the last thing I would ever want to see on a national suicide prevention lifeline is an abandon rate. People who called and were kept on hold and simply gave up and hung up. So there's a great deal of improvement that needs to be done with assuring that there's sufficient capacity in the system that all calls are answered and that they're answered within a few seconds time. You can see then what the breakdown is between Lifeline and the Spanish version of Lifeline and veterans making calls. This is a slide of calls that are answered in a state versus out of state. Vibrant has as a standard that 80% or more of all calls are answered in state. I know here in New Mexico, we exceeded that some time ago, and that more than 87% of all our calls in the state are in fact handled locally, but that's not true in a lot of cases. You got to remember that, and we have an old adage that once you've seen one state, you've seen one state. And what I mean by that is that every system has been structured very differently, has a different history, culture, et cetera. And there are a lot of call centers around the country that don't have full-time salaried staff. They're staffed by volunteers and they have limited capabilities. This is a slide of the US showing in-state call rates, so that those that are red, the call answer rate in-state is less than 66%, and those in green are over 90%. So you can see where your state tends to stack up on that variable. If you want to see your individual state report on volume and in-state answer rate, I have a link there that you can reference. Vibrant is looking at volume projections so that states can project their costs and know how to build their capacity and who's most likely to use this resource. And this can be from folks that may have behavioral health conditions, have a lifetime exposure to traumatic events, who've never accessed the service. There can be folks that are active in treatment that will use it. And then there's simply the general population. And I might add that while this is such a hopeful and comprehensive public policy agenda that I think offers us so much, there are detractors. There are those that not only are opposed to the phone surcharge fee. They can be opposed to using GPS technology because people are concerned about the government is going to know, where I am. There are turf issues. Um, there is a lot of advocacy around 988 having either a statewide crisis call center from which mobile crisis teams are centrally dispatched versus some states like Oregon, for example. Every county has their own crisis call center, but they're not affiliated with Vibrant. And they still want to maintain that local resource. Their clinicians on the line, and if they have a peer-to-peer warm line, certainly know their local community than perhaps somebody located in a central statewide number or a regional call center. So there are a lot of things that need to be balanced as this begins to take shape in your respective states. There are various volume projections that Vibrant is using. Every state now has a Vibrant fact sheet with projections on what the utilization is anticipated to be around 988. And overall, I think they tend to be on the conservative side, but they have made a number of assumptions and come up with basically 3 levels of demand: minimal demand, moderate demand, and then extensive demand. So by year 5, you're talking about volume perhaps being as high as 41 million encounters via the 988 system. That's a lot, but the reality is that there are a lot of call centers around the country that aren't affiliated with the Lifeline, and the Lifeline has no data around what their utilization actually is. Part of the balancing act that I was referencing earlier is that some states want 988 to be the central access point for all crises. And they're looking for a consolidation between all the myriads of call center services that may exist in the state. Some states have 211 numbers, 311 numbers, domestic violence crisis line, rape crisis lines, etc. And there are some really strong initiatives to consolidate all of those. In other places, it's just the opposite, to keep things decentralized, have whether it's a statewide or regional call center, have all those calls routed to local call centers for response, which, given the challenges we have around behavioral health workforce, given the financial costs of maintaining all these disparate systems, et cetera, these are all things that are currently being negotiated in state by state across the country.
Could we take a break just to answer a contextual
Yes.
question?
You bet.
Okay, great. So the first one is 988 crisis support for all mental health, behavioral health concerns, including, for example, domestic violence or hate violence. Curious also, when you call 988, it was mentioned that you can press 1 for VA crisis line. Is there a press 2 or other areas it connects to?
The mechanics of how that gets routed, I am not well versed in. So I know that when you press 1, there are veterans that in fact include clinicians and peer support specialists, et cetera, to respond specifically to the unique culture of having been in the military. But where those calls necessarily go, that level of detail I do not have.
Okay. All right, so there's a couple more coming in. Can you clarify the role of Vibrant in 988's implementation? Is it just the privately funded grant opportunities to the 49 states to get the states started, or will there be ongoing role from Vibrant?
This was private money that Vibrant used for the state planning grant. Um, so that's very different than the funding that Vibrant gets and will continue to get in overseeing the 988 system, and that funding comes directly from SAMHSA.
Okay. Great. So along those lines, is Lifeline and Vibrant being used interchangeably?
In essence, yes.
Got it. Okay. Does this provide API languages?
I'm sorry, what was that?
Does this provide API languages?
Um, this is one of the things that I know is um, part of the expectations of the FCC and Congress. Um, and I don't quite know yet and haven't seen an advisory from Vibrant around how much of those needs are going to be technology enabled and what capabilities there will be to meet a variety of unique needs and not just those around language.
Yeah, so ongoing to be determined. Okay, and the last question we have is, did I see something like this 988 is for ages 12 and above, or any for any ages?
It's intended for any age. And in fact, in states that I'm currently working with, um, and this isn't unusual, what we always seem to get into when building systems about to what degree do we centralize versus decentralize. And so there are strong advocates who want uh, a call center to be able to have generic clinicians and people with lived experience who can handle any type of call from any type of caller. And there are those who want to be able to have customization um, uh, so that there may be call center resources, mobile crisis teams that are specifically for children, youth, and families, for example, or other special populations. And I think this is going to look different state by state, and I'm seeing it going both ways.
Got it. Okay, great. Thank you.
I think the bottom line suggestion I would have for those that are in attendance and are particularly interested in learning more and being active around these developments is to connect with your trade association for behavioral health or your provider organization in your state, et cetera, to be aware of how state planning is occurring. In Oregon, for example, they've got a governor's planning task force. In my home state here of New Mexico, I sit on a task force that's convened by the Behavioral Health Authority in the state. Many states, because they don't have to go through the procurement process, if they contract with a state university, have contracted with their leading state university to facilitate the planning around this initiative. So the last thing I would want is that you've got some strong interest, motivation, ideas, etc., and that your voice is never heard. This stuff is being cooked right now. So if you've got some secret sauce that you want to lend to this effort, um, find out how to get input into whatever the planning initiative looks like in your respective states. And many of these initiatives have a variety of working subgroups that are eager to have people participate. Um, This is simply some of the initiatives around capacity building grants that SAMHSA has provided even prior to the 988 initiative. And you might be from one of these states that are listed. In addition to that, there have been states who've made their own appropriations around capacity building around crisis call center services. For how the grants were structured from Vibrant for this planning initiative, there was one base amount, 125,000. If you had 1 to 2 centers, and then if you had more than that, it increased incrementally so that the $9 million was awarded to all 49 states, as we talked about earlier. The grant funds are to be intended to be used between February and September 20th of this year. These are some of the requirements in terms of specifying the positions that will be needed by discipline. There are a variety of training and technical assistance initiatives that Vibrant and other entities are currently offering. There are monthly coalition meetings on a national basis. And we already talked about the draft and final plans that are expected by each state. So be aware that these are some of the requirements, and final decisions will rest between the Lifeline and that should say SAMHSA, basically. And I think you'll see a great deal of variability by states. Some people have asked me, well, what happens if a state refuses to implement 988? So for example, in Montana, since their legislation failed, what's that going to mean? Well, I suspect that there will be a capability for someone in Montana to call 988, and whatever resources that they've had available up to this point will continue to still operate. But I can't imagine that the anticipated increase in call volume with the same capacity is going to end well. What happens when the abandonment rate increases because there's simply a call volume that the traditional call centers simply can't accommodate? So I don't know if I need to spend much more time in talking about the state grants and their requirements. It's critical that in order to participate in the system, that any call center be a Lifeline affiliate. And while there is some openness to consider additional affiliates in the country, I know that Vibrant wants to keep those limited. And so a state could potentially increase or devise a structure that would include non-affiliates, and then there's going to have to be negotiations between Vibrants and SAMHSA and the state with regards to how that disparity is in fact resolved. So the reality is that this is upon us. The trajectory for implementation is incredibly fast. I know states are dancing as fast as they can. I know here in my home state of New Mexico, the opportunity was missed to introduce legislation. We're the only state in the country that still has a voluntary legislature. And next year, we only have a 30-day working session, which is going to be incredibly difficult to get this legislation passed. There will, of course, uh, be suicide prevention plans incorporated into this planning. We have to expect the growing demand, as we talked about earlier, and exploring a variety of different funding models. As you're probably aware, Medicaid is the major funder in the United States for behavioral health services overall. Um, there's at least one state that I know of that currently has Medicaid billing occurring for crisis callers. That does require identifying a caller, determining that they are in fact a Medicaid recipient, and then they bill for that call. Um, Other states want to assure the anonymity of a caller. And one of the things I wanted you to be aware of is that there is such a thing as a um, Medicaid administrative match that's at 50% within Medicaid. And I use that in administering the New Mexico Crisis and Access Line, where we did an annual survey, and 50% of all the callers were Medicaid recipients. And given the 50% match, that meant that I could get half of that 50%. In other words, 25% of all the calls paid for by Medicaid. So I'm just pointing that out as a potential resource that isn't often tapped as a way to further fund 988 services. And we went over these requirements earlier. I encourage you again to go to the crisisnow.org website so that you can learn more about the specific components of a crisis response system. And related to that, if you want to be able to have police drop-offs, you've got to be able to say yes to admissions 100% of the time. But EMS is another ball game entirely. They're primarily ruled in terms of payment by Medicare. And the only place that they're really allowed to drop somebody off is an emergency department. CMS has a variety of pilot projects going on now that are called ET3, which enables an EMS service to designate alternative drop-off locations, including a crisis stabilization center. And that's the only way EMS can, in fact, get paid for drop-off. So EMS heads directly to emergency departments unless we're able to get them to be paid otherwise. So in terms of implications regarding all of this, we tend to think of these crisis services as the canary in the coal mine. We can, particularly with data collection and good data analytics, pick up on trends that are occurring in society and be able to make potential policy shifts much more quickly to intervene with regards to whether it's mass shooting or increased suicides, homicides, etc. Geography does matter in planning these services. You may set up access standards for a mobile crisis team being dispatched, but there's a mountain range between here and there, and you have to drive around that. And you've got to be able to accommodate the travel time around mobile crisis, which fee-for-service models tend not to pay for. So this requires new payment models. Services need to continue to be localized. They have to be customized to the needs of those who are utilizing them. And technology is key. And I will spend a little bit of time on this. Behavioral Health Link in the state of Georgia operates the the Georgia Crisis and Access Line. They have been the innovators around crisis center call technology. They do have their call center GPS enabled. So they know where every call is originating, but they also do statewide centralized mobile crisis team dispatch. So they're able to see in real time where all their mobile crisis teams are in the state, which ones are currently active, engaging someone, and which ones are available, and then dispatch the closest available mobile crisis team. In addition to that, they have the bed registry technology, which many states now have, so that they know where the next available bed is in real time. The mobile crisis team, this call center, does not have to spend um, sometimes hours trying to figure out where the next available bed is to transport somebody who could not be stabilized, has an acuity level that warrants a higher level of care. In addition to the bed registry, they also require in Georgia that outpatient providers link electronically their appointment scheduling with the statewide crisis call center. So a mobile crisis team, if they've seen somebody at 2 in the morning and want them followed up at the nearest mental health center at 8 o'clock the next morning when they open, that mobile crisis team can go into that scheduler and schedule that person for that 8 o'clock appointment. This means changing to an open access model in the way of handling internal scheduling within our provider organizations. But in order to get the continuity of care and make the system responsive to people's needs, that's what it's going to take. And stakeholder, go ahead.
Thank you. So yeah, along the lines of consumer centric and customizing, I have a question here that says, has anyone identified the homeless in the special populations?
Absolutely. Absolutely. It isn't just about being homeless, which is key. And I'll never forget it. An individual approached me a good many years ago now and said, you professionals have got it all wrong. He said, for years I was told, and this was somebody with a history of severe mental illness, I was told if I just got a job, everything would work out. He said, I've had hundreds of jobs. The reality is I could never keep it because I didn't have a home. And once that person had a stable home, that's when everything shifted and that person was able to sustain recovery and became a tremendous advocate. Um, but the reason I said that it's more than just homeless, it's around all the social determinants of health and the inequities that are experienced in our society. So it isn't always about the call center being able to link with clinical services around, and this is an area that people get confused about. They tend to think of crisis services as a treatment service. And I would hold out to you that this is not a treatment service. We're not about having somebody go and be face to face with a mobile crisis team or to a facility-based crisis service to be diagnosed, get a treatment plan, get medications. That's not what this is about. This is about determining what was the baseline functioning for an individual and what happened that disrupted that baseline for them. And how do we get them to a point where they can again function at that baseline? And oftentimes that can mean, a stable living environment, or at the very least, some transient housing. It can mean, how do I eat? How can I avail myself of supportive education or employment? And the list goes on. So it's much bigger than our siloed thinking around, clinical service delivery.
Thank you.
I mentioned to you earlier that I had a map of legislation, and this is it, and it's already outdated. Utah and Virginia and Washington State have all passed their 988 implementation model legislation. As I mentioned to you, in Montana, their legislation failed. You can see all of the white states where there's been no legislation yet introduced. So I would apprise you again, keep in touch with your applicable professional associations and advocacy associations in your state who are all tracking this legislation. They know when there are upcoming hearings. If you want to advocate for something or you want to oppose something, etc., know what committee a particular piece of legislation is in, where it is in the hearing process, etc. And again, use this as an opportunity for your voice to be heard. And this is a quote from the administrator of the Lifeline. 988 is the watershed moment in the history of crisis and behavioral health care in the US and presents an opportunity to reach millions in emotional distress while destigmatizing help seeking. Collaboration is needed between crisis centers, state and local authorities, mental health advocates, and federal agencies, including SAMHSA, to determine a 988 crisis response model that meets the needs of their state and incorporates the best practices in crisis coordination while providing effective support for people in crisis every day. And I don't normally like to read to people, but I thought that summed up my message for you today as well as any. So any further questions?
I wanted to edge in here to see, Wayne, are you able to see the Q&A box? I thought it might be better if you could direct it or if you wanted to facilitate.
You mean the chat box?
There's a chat box and there's also a Q&A box. They're
Well,
separate.
nothing was in the Q&A box, but there's stuff in the chat box.
Or I'm happy if folks want to go ahead and just raise questions in the chat box. I'm happy to read them out as well. But in the meantime, if you see questions in the chat, yeah, we could definitely go to it. One thing I wanted to bring up was to follow up on the recommendation you had shared earlier in the presentation around connecting with trade organizations or subgroups within anyone's respective state to be aware of how state planning is occurring. I'm wondering if you could elaborate on that with a couple examples of maybe trade groups you know of or how to find them. I just thought that was a rich point that could be elaborated on.
Well, I'm doing a lot of work with the state of Oregon right now, and the Oregon Association of Community Mental Health Programs is an association of the community mental health centers in Oregon, and they're very active in this initiative. And as a provider association, very active at the state level in advocacy. I know here in New Mexico, the New Mexico Behavioral Health Providers Association is similarly involved. In some states, it's the Public Health Association, or there's a council for behavioral health. These take different forms in different states. NAMI, for example, has affiliates in every state and a lot of local affiliates. They're involved. Mental Health America has affiliates around the country. They likewise do their own respective advocacy around this and related initiatives, as just some examples come to mind.
Okay, great. So here's another question, 988, will it be available in other languages? I know we had that question earlier, but I'll let you take it on.
Yeah, it will. It's just, I don't know what form that's going to take. And, you know, just like any of us can take any communication we have anymore and get it translated within seconds into myriads of languages, but it doesn't always translate very well. So I think it's given the kinds of issues that we're talking about, it's going to need to be more sophisticated than that. And I'm not sure yet what the solution is going to be.
Got it. Okay. So next question is, as practitioners, how can we help or support with this initiative?
I don't know what more to say than about that than I already have. Go to the crisisnow.org website. Um, there is a resources tab, and there are a number of tools. Chief among them, in my estimation, is the Crisis System Capacity Calculator, where you can, in fact, put in the population for your town, city, state, region, and it will populate and calculate for you, given the algorithms that we've built, how many acute beds you need in your state, psychiatric beds, um, how many crisis facilities you need that operate with recliners and take voluntary and involuntary admissions, how many crisis centers you need, and how many beds you need for crisis stabilization, how many mobile crisis teams you need to have operating in the state, making, of course, the accommodations for operating in more rural or frontier areas, et cetera. So that's one of the first places I would encourage you to go. You can keep track of these developments, like I said earlier, on Vibrant's web portal. If you just Google Vibrant, it will come up, and you can be apprised of those developments. And like I said, I think your statewide associations are keeping abreast of developments around the planning in your respective states. So if you want to have more locally relevant information, I would propose going to those resources.
Great. There's no questions as of now. See if folks have other questions. I'm also scrolling through the full list of what we've gone through.
Well, we probably wore everybody out by now. I know I'm getting to the point where I can barely talk.
It's been a really wonderful presentation. A lot you've covered so far.
Thank you.
And I know we've sent out the deck, the presentation deck. So you all should have that resource available to you. Our IT person put it in the chat box. And let's see.
You know, another resource, now that I'm thinking of it, is SAMHSA published last year their national guidelines for behavioral health crisis care. That's available on SAMHSA's website. And it delineates the various components of the crisis now and the principles behind it, and is a good guidebook for understanding and knowing. I'm going to say it's basically kind of a toolkit around building these types of services.
Wonderful. Okay, well, there are a couple of things I wanted to cover before folks might need to head off for the rest of their workday. And I want to say a big thanks again to you, Wayne. This has really been an incredible source of information about this initiative. So thank you. And thank you all for joining us and taking time out of your day to learn more about this.